My name is Dr. Anthony Massaro, Associate Physician at Brigham and Women's Hospital in Boston, Massachusetts, Director of the Medical Intensive Care Unit, and Instructor of Medicine at Harvard Medical School. It's my pleasure today to be able to talk to you about the use of the ABCDEF bundle in our patients on mechanical ventilation. I do not have any disclosures to report. The outline of what we're going to touch on today is first to remind people of the individual elements which make up the ABCDEF bundle, and then talk briefly about how they work together in aggregate. We'll then next turn to what are the reasons why we would want to implement this bundle in an ICU, what would be the goal of our implementation. Next, we'll turn to the individual bundle components, and for each of them, what does it mean to actually use this process of care? And for many of them, show some data about the impact that it can have on patient care. Finally, we'll then turn to a recent study that looked at the impact of implementing the entire bundle in a hospital system composed of community hospitals. This slide details the 6 individual components of the bundle. A, standing for the assessment, prevention, and management of pain. B, meaning both the performance of a spontaneous awakening trial and a spontaneous breathing trial in a coordinated fashion. C, the choice of analgesia and sedation. D, focuses on the problem of delirium. How do we assess it, prevent it, and manage it? E, assures that we are maximally mobilizing our patients on mechanical ventilation. And the final component, F, assures that we are engaging families who are involved in the care of these critically ill patients. If you look at the group of these 6 components of the bundle, we can see that they are very interdependent. As an example, performing a spontaneous awakening trial is a mechanism by which we reduce the amount of sedation patients are receiving. That reduction of sedation, especially benzodiazepine dose, will affect the incidence of delirium. So individual components of this bundle are interdependent. I will show you data how many of these are evidence-based. And the final thing we can see looking at this group of 6 interventions is that in order to successfully implement this in an ICU, it really requires a multidisciplinary team. There needs to be involvement of physicians, nurses, physical therapists, respiratory therapists, and pharmacists. What is the goal of the ABCDEF bundle? Well, I'm hoping to show in this talk that the aim of this is that we're going to be able to improve both the immediate and the long-term outcomes for our critically ill patients. And I really want to focus on the fact that we are looking not only at the experience that the patient has while they're in our ICU on mechanical ventilation, but really on what we can do while they're with us to improve their care in their functional status long after they've left our unit. It is really our responsibility not only to get them over their acute episode of critical illness in mechanical ventilation, but we need to position them for long-term success. We know that we do a better job now taking care of patients who are on mechanical ventilation. This slide shows some data about the changes in the odds ratio of death in patients who are on mechanical ventilation over a 12-year period. This study looks at over 18,000 patients, and the bottom row shows that there is a significant reduction in the ratio of death from 1998 to 2010. For this increased percentage of patients who survive their episode of mechanical ventilation, we know that over a year, their pulmonary function returns close to normal. Shown on this slide is data of a group of patients with ARDS with their FEV1, FVC, TLC, and residual volume all returning to greater than 85% of predicted within the first year. While their pulmonary function improves, their functional status does not return to baseline. Here is data from that same study showing that at 12 months, these patients are only able to ambulate in 6 minutes, a distance 66% of predicted. Among this cohort, slightly less than half are able to return to work within the first 12 months. Here's some additional data looking at a variety of different domains on patients' self-reported functional outcome. And this includes the patient's emotional role and mental health. This is a survey that the patients answered on a scale of 0 to 100. And shown on this slide are the patient-reported outcomes for each of these domains compared to the expected value of a matched cohort. In another lecture in this series, you'll be hearing about the post-ICU syndrome, or PICS. We know that our patients on mechanical ventilation, critically ill, have long-term impact in their physical, cognitive, and psychiatric outcomes. The ABCDEF bundle, you'll see, is aimed to address these longer-term issues as well as the short-term issues. In summary, what are our goals of implementing this bundle? Well, we will again, the aim is to improve short-term outcomes, such as the incidence of delirium and the length of delirium, the length of time on mechanical ventilation, the length of time patients spend in our ICU or in the acute care hospital, reduction of mortality, and improving the patient's functional status at the time of discharge from the hospital. But also importantly, hoping that showing that our interventions with this bundle can improve the longer-term sequelae of the post-ICU syndrome when patients are long discharged from our units. We will see as we go through this that these individual elements of the bundle are meant to support the implementation of the 2013 Clinical Practice Guidelines for the Management of Pain, Agitation, and Delirium, supported by the Society of Critical Care Medicine. I will also mention here that the Society of Critical Care Medicine's ICU Liberation Campaign has launched a quality improvement initiative related to implementation of this bundle. And on the website, which I've shown on the slide, there are tools supporting its implementation, as well as additional data showing the effectiveness of the bundle. Let's next turn to the individual elements of the bundle. So the first is the assessment, prevention, and management of pain. Why is the assessment of pain important? Well, pain is common in our patients who are in the ICU. Over 50% of the patients in medical and surgical ICUs report pain during their stay. There are significant long-term sequelae of pain. It is well established that there's an increased incidence of PTSD in patients who have pain, and there is an association of pain with the incidence of delirium. Assessing pain can be challenging, but if you're going to minimize pain and be able to treat it effectively, you have to be able to be assessing it. The gold standard tool is the patient's self-reported assessment of pain. This is usually on a 1 to 10 scale. For many of our patients who are on mechanical ventilation, this is not possible. So there are 2 other recommended scales that can be used in the ICU. The first is the Critical Care Pain Observation Tool, or CPOT. The CPOT is made up of 5 subscales. These include facial expression, body movement, muscle tension, compliance with the ventilator, or if the patient's not intubated, vocalization. Each of these subscales is rated 0 to 2, with a total score of greater than 3 indicating significant pain. Another option is to use the Behavioral Pain Score, or BPS. This has 3 subscales: facial expression, upper limb movement, and ventilator compliance. These are all scored 0 to 4, with greater than 5 indicating significant pain. It is to be compliant with this component of the ABCDEF bundle. You need to institute in your ICU a mechanism to regularly assess pain using one of these scales. The care that we provide in our ICU is associated with pain. The procedures that we perform are associated with pain. Here's a study showing 4 of the most painful procedures that we perform: chest tube removal, wound drain removal, placement of an arterial line, and the very commonly performed endotracheal tube suctioning. The second component of the A part of the ABCDEF bundle is to be able to prevent and manage pain. Whenever we're thinking of doing any of these procedures, we need to make sure that we're adequately treating the patient's pain so that we're preventing it from becoming extreme. So recommendations based on the pain, agitation, and delirium guidelines are to think about preemptive analgesics or non-pharmacologic interventions prior to our procedures to minimize discomfort. They specifically mention chest tube removal because of the high association that has with pain. For treatment of pain, intravenous opioids are considered the first-line drug class of choice, as long as the patient is having non-neuropathic pain. Non-opioid analgesics should be considered an adjunct to reduce the total amount of opioids that patients are administered. And finally, if patient has neuropathic pain, using gabapentin or carbamazepine should be considered. We turn next to the spontaneous awakening trial and the spontaneous breathing trial. Spontaneous awakening trial, as people know, is the complete cessation of all continuous IV sedation, as well as cessation of the continuous IV narcotics, as long as they are not required for pain control. When these are stopped, the patient is assessed, and there is an assessment of their level of agitation. If there is agitation or dysynchrony with the ventilator, the continuous IV sedation can be restarted, but it is to be restarted after a bolus at half of the prior dose. There can be then subsequent titrations to minimize the total amount of sedation that the patient is being required. And that's really the goal of this intervention, is to minimize the total amount of sedation. Here is a seminal study in 2000 showing the impact of the daily cessation of sedation. This was a study performed in 128 adults in a medical intensive care unit. And what we see here is the intervention being associated with a decrease of 2.4 days in the length of mechanical ventilation, statistically significant, as well as a significant reduction in the total length of time in the intensive care unit. Not shown on this study, but also not shown on this slide, but also seen in the study, was that patients who had the spontaneous, that patients who had the daily cessation of sedation went for a less number of tests to evaluate their neurologic function. They had also a decreased total midazolam dose. Of note in this study, there was no increase in the amount of self-extubation. In this element of the bundle, there should be coordination of the spontaneous awakening trial with a spontaneous breathing trial. We know that independently, a spontaneous breathing trial is the best performed on a daily basis in patients who pass a safety screen, is the best way for us to assess patients who are ready to extubate. Here's a study from 2008 performed at 4 tertiary care hospitals, enrolling 336 patients, and with the major endpoint being how long did it take for patients to be able to breathe on their own. In the intervention arm, patients got a daily spontaneous awakening trial paired with the spontaneous breathing trial, as compared to the patients in the control arm who got the usual titration of sedation with a spontaneous breathing trial. What you can see here is that there is a significant increase in the length of time that the patients who got the paired SAT and SPT had off mechanical ventilation. In this study, the patients with the paired intervention had both a significantly reduced length of stay in the ICU as well as the total hospital stay. Interestingly, it was also noted in this study that the 1-year mortality was less for the group that had received the paired trial. We turn next to choice of analgesia and sedation. This is important because being thoughtful of the type and the amount of sedation has shown to impact patient outcomes. The major focus in implementing the bundle around this element is to have a strategy in place that will minimize sedation. We already talked about one of these strategies, which is the performance of the spontaneous awakening trial. Another mechanism to do this is to make sure that your orders for sedation are goal-directed, so that the order will have tied with it titration of a sedation medication to a particular sedation score, such as a RASS score being of 0 to -1. If we're going to be attentive to the level of sedation we're providing to our patients, just like we discussed in pain management, you need to be able to make sure that your unit is regularly assessing the amount of sedation that patients have. The two scales which are recommended to do this are the RASS score, or the Richmond Agitation and Sedation Scale, or the Riker Sedation Agitation Scale. The RASS scale is a 10-point scale which rates patients all the way from unarousable to combative, and the SAS is a 7-point scale which tiers patients from unarousable to dangerous sedation. In being thoughtful for the choice of analgesia and sedation, there is a recommendation that non-benzodiazepine sedations may be preferred over benzodiazepines. The importance of not sedating our patients can be seen in this study, which I'm showing, which was a multi-center study looking at the differences in outcome in patients who in the first 48 hours had deep sedation versus those who were more lightly sedated. And by deep sedation, those were patients who had a RASS score of -3 or deeper. Among these 259 patients, you can see that time to extubation was significantly delayed among patients who had deep sedation early in their course of mechanical ventilation, and that the Kaplan-Meier curve shows a significant increase in mortality among those who were deeply sedated. I want to show one other study here looking at the two different strategies that we mentioned to minimize the total amount of sedation use. This is a study involving 430 patients in 16 medical and surgical intensive care units, looking at the two strategies to minimize sedation. One was one arm, it had patients getting the protocolized sedation that we discussed, where the sedation order was titrated to a sedation scale. The second arm is using that sedation scale paired with the previously described daily spontaneous awakening trial. The primary outcome in the study was time to extubation. The secondary outcome were the length of stay in the hospital, as well as sedation and total opioid use, and then finally unintentional device removal. And this slide shows that both strategies were equally successful in getting patients off of mechanical ventilation. And then if in this study setting you carefully titrated your sedation to a sedation scale, there was no benefit of adding the spontaneous awakening trial. The next element that we're going to turn to is D, which is the important problem of delirium. Delirium is a syndrome of acute brain dysfunction characterized by inattention, fluctuating mental status, altered level of consciousness, or disorganized thinking. Delirium is common in our mechanically ventilated patients. It can be seen in up to 81% of patients who are on mechanical ventilation. When patients develop delirium, it has a significant impact. It increases the amount of time patients are on mechanical ventilation. It lengthens both their ICU and their hospital length of stay. It increases their cost for us in the hospital. It's associated with an increase in mortality. And very importantly, it's associated with longer-term sequelae when patients leave the ICU. Their cognitive impairment there is an increase in cognitive impairment after they've left the ICU when they've developed delirium in our ICU. Here's some data from a meta-analysis showing the impact, showing some details of the impact of developing delirium when patients are in our ICU. This is the impact on the length of time on mechanical ventilation, and this showing in these 10 studies that this increased the time on mechanical ventilation by 1.79 days. Among patients who develop delirium, their length of stay in the ICU is longer by 1 day and 9 hours. And finally, their odds ratio of hospital mortality is 2.19. So clearly, delirium is a major problem, both while they are in our ICU, and impacts what's going to happen to patients after they've left our ICU. Similar to pain and agitation management, the first step in appropriately addressing delirium and meeting the D component of the ABCDEF bundle is to make sure in your unit that you are regularly assessing for the presence of delirium. The most commonly used scales that are recommended to do this are the CAM-ICU, the Confusion Assessment Method ICU, or the Intensive Care Delirium Screening Checklist, the ICDSC. Once you're regularly assessing delirium, what can you do to prevent delirium from developing as part of this bundle? Well, this is, again, showing the recommendations from the 2013 Pain, Agitation, and Delirium Guidelines. There is a strong recommendation for early mobilization, and we will see some of that data in the next section. But importantly, there is no recommendation at the current time for a pharmacologic delirium prevention protocol. And in particular, they do not suggest that either haloperidol or atypical antipsychotics be administered to prevent the onset of delirium. Once delirium has developed in our patients, what can we do to minimize it? Well, again, as per the pain, agitation, and delirium guidelines, there really is no evidence that treatment with haloperidol reduces the duration of delirium. There should be consideration of the introduction of atypical antipsychotics to reduce the duration of delirium. More data is needed for this to be a strong recommendation. And finally, there should be consideration for patients who have delirium which is not related to alcohol or benzodiazepine withdrawal, to consideration to use dexmedetomidine rather than increase benzodiazepines to reduce the duration of delirium. We next turn to early mobility. The E component, or the early mobility component, is really to make sure that every day you are assessing your patients with a safety screen to see if they can be mobilized, and if they do, make sure you're maximally mobilizing. Here is a study from 2008 showing that that we can be successful with early mobility in our ICU. This is a prospective cohort study which used a mobility team to help mobilize patients early. This mobility team was made up of a critical care nurse, a nurse assistant, and a physical therapist. These were patients who were enrolled very soon after the onset of mechanical ventilation, and at baseline, the patients did not have prior to their admission any problem either with walking or baseline cognitive impairment. The primary outcome of this study in 2008 was to see could this mobility team really successfully increase the proportion of patients who were able to begin PT in our ICU. This slide shows the important outcome from this study, and the answer was a resounding yes. That more of these patients who were seen by the mobility team had at least one PT session while they were in the hospital, and earlier, and an increased percentage had their initial PT session while they were in the ICU. This early mobilization could be performed without any increase in any complications during the attempts to early mobilize these patients. And here are some significant outcomes. You can see here there is a significant decrease in the amount of time it took for the patient to be able to get out of bed. There was not in this study seen a significant reduction in the length of time on mechanical ventilation, but they did see when the outcomes were adjusted for body mass index, Apache 2 score, and vasopressor use, that there was a significant reduction in the length of stay in the ICU and in the hospital for the patients who had the intervention of the early mobility team. Here's a second study showing the impact of an early mobilization program. And in here, early mobilization was paired with performance of the spontaneous awakening trial. In this study, the control group just got the spontaneous awakening trial and usual care. Again, patients enrolled in this study had at baseline were independent. It was 104 patients who had the intervention performed early, and again in this study we can see that they looked at the very important outcome of the incidence of delirium, and the patients who had the early mobilization had a significantly reduced amount of days with delirium. These patients in this trial did show that there was a significant increase in ventilator-free days. There was a trend, but not statistically significant for the length of time that the patients had in the ICU. So early mobilization has many benefits, and this has been supported by multiple other studies. There is a reduction in delirium, many studies showing a reduction in the time on mechanical ventilation and length of time, and decreased length of time that these patients stay with us. The final component of the bundle is family engagement. We know that ICU admission has significant impact on the family and friends of the patient who is critically ill. This study from 2005 shows that overall incidence of post-traumatic stress syndrome on family members of patients who are in the ICU was 33%. There are particular family members who are impacted even in a more powerful way. In this study, the family members who felt that we did not do a good job providing complete information to them had a post-traumatic stress incidence of 48%. It was even higher when the family member had a relative who died in the ICU, a relative who died after having to make end-of-life decisions in the ICU, and the highest among family members who were involved in the end-of-life decision-making, up close to 82%. It's now well recognized that similar to a post-intensive care unit syndrome for the patient, there is a post-intensive care syndrome for the family. This is comprised of elements such as acute distress disorder, particularly well documented in parents of patients who have parents of children in the ICU. We mentioned post-traumatic stress disorder. It also involves anxiety and a significant longer-lasting depression in the family members of patients who are in our ICU. Interventions that we can do in our ICU can decrease these long-term sequelae. One important intervention is to have structured information sharing with the family during family meetings. A second way to minimize some of these longer-term sequelae is to make sure that your ICU has implemented interventions to increase family presence and participation. This can be done in a variety of different ways. The unit should have an open visitation policy, so therefore not being restrictive as much as possible in when family can visit. A second way is to develop a system which supports having family involvement on rounds. And more recently, many ICUs have turned to seeing how the patient family members could be supported if they wanted to be present at the time of codes or performance of procedures. A final type of engagement that can increase family engagement is to be thoughtful about the use of both ethics and palliative care consultation to help with key decision-making that the family may have to make during times of critical illness, especially when end-of-life decision-making is needed. In January of 2017, the Society of Critical Care Medicine endorsed guidelines for family-centered care in neonatal, pediatric, and adult ICUs. This reference provides a lot of details about what it means to provide family-centered care, and I have the reference here for your further review. So I'd like to next turn to a recent study looking at what is the impact of implementing that can be seen in implementing all 6 of these elements of the ABCDEF bundle. So this was a study that was performed in 7 California community hospitals. It involved over 6,000 patients, and the 2 outcomes were to really look at what was the association between the bundle performance and the outcomes of 1, hospital survival, and 2, delirium or coma-free days. This study was performed on patients both who were on mechanical ventilation and as well as not being mechanically ventilated. Obviously, the patients who are not mechanically ventilated would not get the components that were specific to mechanical ventilation. This study started at a time when the definition of the individual elements of the ABCD bundle were slightly different, so it will provide some detail of that. This slide shows the individual components of the bundle that they used for this study. And I think it's important to look at it to see exactly what was the metric that they instituted at their 7 hospitals to show that a patient was compliant with that component of the bundle. So in this study, the A element of the bundle stood for performing a spontaneous awakening trial, and that meant that all continuous IV sedation had to be stopped. B stood for the spontaneous breathing trial, and patients had to either be put on pressure support 5/5 or a T-piece. C, that there was some coordination of the performance of the SAT and the SBT, and that was documented by the nurse and the respiratory therapist confirming on rounds that these 2 interventions had been coordinated. The second component of the C element of the bundle was that the pharmacist would attest that the pain medication and the sedation followed the guidelines set out by the pain, agitation, and delirium guidelines. D, for delirium, the metric was to make sure that over the prior 24 hours that the CAM-ICU had been used to document that there had been a continuous assessment of the presence for delirium. E, on rounds, it was attested to that the patient had been maximally mobilized over the prior 24 hours. And F, for family engagement, was that the patient or the family had either participated in rounds or that a family conference had been held to update the family over the prior 24 hours. Well, what was the impact of implementing this bundle? This slide shows the survival plotted in relation to the total compliance with the bundle on the left and partial compliance on the right. For every 10% increase there was in total bundle compliance, there was a 7% higher odds ratio of hospital survival. And for every 10% increase in partial bundle compliance, there was actually a 15% improvement in survival, showing the significant impact of when you were able to implement all elements of the of the ABCDEF bundle. There was a similar improvement seen in the number of delirium and coma-free days. The graph on the left shows patients who had total bundle compliance, the increase in delirium and coma-free days, and on the right, the partial compliance. What was seen was that for every 10% increase in total bundle compliance, patients had a 2% increase in the delirium and coma-free days. And for every 10% improvement in partial compliance, there was actually a 15% improvement in delirium and coma-free days. So this study further supports, on a very large scale, the largest scale yet reported, that there can be a significant impact in our patient outcomes by implementing this coordinated 6-component ABCDEF bundle. So in summary, I hope we've been able to show that implementation of this ABCDEF bundle can improve patient care. It improves outcomes not only in the short term while we're caring for patients in our ICU, but has the potential to affect the outcome both for the patients and for their family long after they've left our ICUs. Secondly, that many of the elements of the ABCDEF bundle are ways to implement the pain, agitation, delirium guidelines of 2013, supported by the Society of Critical Care Medicine. And finally, showing some data that the ABCDEF bundle can be successfully implemented in a research environment, but also can have significant impact as a quality improvement initiative in any hospital in any hospital setting. What it does require is a commitment and the coordination with a multidisciplinary team. That this team needs to be comprised of physicians, nurses, respiratory therapists, physical therapists, and pharmacists. But with this, we can reach the goal of improving short and long-term patient outcomes. Thank you. So there's 2 questions. I think I'm supposed to read through the questions. Okay. So question 1, an 80-year-old male with a history of COPD is admitted to the ICU with pneumonia and hypoxemic respiratory failure. Mechanical ventilation is initiated, and he is started on continuous IV midazolam for sedation. Which of the following interventions is not indicated to minimize the risk of delirium? A, spontaneous awakening trial. B, midazolam ordered titrated to a RASS of 0 to -1. C, initiation of haloperidol delirium prevention protocol. D, mobilization at the earliest time possible. The answer, which of the following interventions is not indicated to minimize the risk of delirium? The appropriate answer is C, initiation of haloperidol prevention protocol. Daily interruption of sedation and goal-targeted sedation titration are 2 well-established strategies to minimize the total amount of sedation use. We talked earlier about the fact that sedation, particularly benzodiazepines, are associated with increased incidence of delirium. Minimization of benzodiazepine, early mobility studies have demonstrated reduced delirium rates. There's no evidence to support protocolized use of haloperidol to prevent delirium. Actually, you know what? I'd like to read this slide over one more time. Question 1, answer. Which of the following interventions is not indicated to minimize the risk of delirium? 1, let me start it again, sorry. Question 1, answer. Which of the following interventions is not indicated to minimize the risk of delirium? And the correct answer would be C, initiation of haloperidol prevention protocol. Daily interruption of sedation and goal-targeted sedation titration are two well-established strategies to minimize the total sedation dose. If that sedation is with benzodiazepines, we know that, let me scratch that. Question 1, answer. Which of the following interventions is not indicated to minimize the risk of delirium? The correct answer is C, initiation of haloperidol prevention protocol. Daily interruption of sedation and goal-targeted sedation titration are two well-established strategies to minimize total sedation dose. This patient is on midazolam. We know that minimization of benzodiazepine dose is associated with reduced incidence of delirium. Early mobility studies have demonstrated reduced delirium rates. The correct answer is C because there is no evidence to support protocolized use of haloperidol to prevent delirium. Question number 2. A 65-year-old female with stage 4 non-small cell lung cancer is admitted to the ICU with chemotherapy-related pneumonitis and acute respiratory failure. At home, she is on standing and, as needed, oxycodone to control pain from multiple rib fractures and spine metastases. Mechanical ventilation is initiated. She is placed on continuous midazolam and fentanyl drip. Which of the following interventions would be most appropriate to minimize duration of mechanical ventilation? A, daily spontaneous awakening trial with cessation of continuous IV midazolam and fentanyl. B, daily SAT with cessation of continuous IV midazolam and continuation of fentanyl to control any pain. When needed, restart the midazolam at the prior dose. C, to transition from midazolam and fentanyl to propofol. Or D, assure that all sedation orders are written to titrate to a RASS of 0 to -1 and opiate to titrate to pain. The answer to question 2. Which of the following interventions is most appropriate to minimize duration of mechanical ventilation? The correct answer would be D. Assure that all sedation orders are written to titrate RASS 0 to -1 and opiate to titrate to pain. Daily cessation of sedation is a well-established intervention to reduce mechanical ventilation days. In this case, option A is not most appropriate since the patient is on chronic opiates at home, and the SAT should be performed with continuation of continuous opiates to control the patient's baseline pain. It would be reasonable to continue this in an equivalent dose to the dose the patient was receiving at home. Option B is not correct because it directs restart of the midazolam at the prior dose, and in the performance of a spontaneous awakening trial, the continuous IV drip should be restarted at half the prior dose and then retitrated. It is reasonable to consider transition from midazolam to propofol for sedation, but this patient needs some opiate as pain must be addressed. So C is not the most appropriate answer. Control of pain into titration of sedation to a RASS of 0 to -1 is the best answer.